Ravindar, hi, Gopalamurugan. We have an external panel and the
Hi,
room is
Dr.
fully packed.
Gopalamurugan.
We can't wait to see what you're going to show, buddy. Off you go.
Good morning, everyone. At the outset, thank you, Hyderabad Valves. Thank you, Dr. Agarwal and Dr. Rath, for including us in this great academics sessions. And it's pleasure to hear Dr. Gopal Murugan's voice. So let me introduce my team. My name is Dr. Ravindar Singh Rao, and here is Dr. Kailash Chandra, intervention structural cardiologist, Dr. Govin Sharma, intervention structural cardiologist. Here is Dr. Piyush and Dr. Prashant Vashne, who's a cardiac anesthetist and specializes in TEs for mitral clip and conscious sedation TAVR. And then our whole team of technicians and scrub nurse. So let's go straight to the history. Case, first slide, please. Next slide. Next one. Next one. That's our team. Next one. So here's an elderly gentleman admitted with shortness of breath since 6 to 7 months, diagnosed as severe aortic stenosis, LV of 50%, double vessel disease with patent stent in LAD, past history of diabetes, hypertension, PCI to LAD in 2018, allergic asthma for 20 years, had a COVID in Jan 2022. Next slide. On echo, the mean peak gradient is 105, mean gradient is 70, aortic valve area is 0.84 centimeters square, good biventricular function, mild pulmonary arterial hypertension. Next slide. ECG is normal sinus rhythm. Next one. And this is the CT scan for the aortic annulus. Here you can see the annulus area is 629.7 millimeters square. The area of the LVOT is 597. So almost LVOT is slightly smaller than the annulus, but a large annulus with no calcium at the level of annulus, no calcium into the LVOT. Next slide. You can see heavily calcified tricuspid aortic valve with all the calcium on the leaflet. The coronary height is adequate. Next slide. And good sized femoral vessels with normal level of bifurcation below the femoral heads. Next one. Next one. Next. So SAVR, TAVR, I think this all can be discussed. Next one, keep going. If TAVR, then what valve we are preferring because this patient has a coronary artery disease. Keep going, next slide. And this is a large annulus. In a larger annulus, we would always prefer a balloon expandable valve. Next slide. Next one. Next one. And then this is a 29 millimeter valve, which is just 3% oversized at the level of annulus, but deep into the LVOT, it's around 10 to 12% oversized. So that's also important, how to size the balloon expandable in a anatomy where the annulus and the LVOT don't match with each other. Next one. Pre-dilatation, yes or no. Majority of balloon expandables, we are not doing any pre-dilatation, but here is a situation where mean gradient is 70 and peak is 100. So we'll assess it during our crossing and assessments. Next one. Next. Next. So our balloon expandable, so pre-dilatation balloon is 23 millimeters. Next one. We are not using any cerebral protection. You know clearly now the data does not support a routine use of cerebral protection. We were using it in the initial phase, but now we have reserved it only for valve-in-valve or a basilica procedure or a heavily calcified arch or a patient who had a prior stroke. So no routine use of cerebral protection device for sure. Next slide. Roadmap, so we're going to have a transfemoral access TAVR with conscious sedation, left common femoral artery 6 French, left common femoral vein 6 French, and our TAV main axis in the right femoral artery. We're going to be doing an ultrasound guided puncture, single proglide with provisional angioceal proglide technique. Next slide. We also want to share that we have submitted an abstract which has been accepted in London Valve. This is the vascular outcome of single proglide with provisional angioceal proglide versus 2 proglide for TAVR. We have been doing this technique since 2018. Next one. And this has been accepted as an abstract presentation. We analyzed 220 patients, first 110 patients with 2 proglides, 105 patients with 2 proglides, and next 115 patients with 1 proglide and 1 angioceal. And the logic is now all the devices have come down from 18 French to 14 French. We should also come down on the number of closure devices. Next one. So this is a busy slide. Next one. But I'm going to come to the conclusions. We concluded in this abstract that single proglide per close technique with provisional second device technique appears to be safer for the current generation lower profile TAVR devices. Above technique of single proglide has shorter learning curve, greater adaptability for newer operators, lesser vascular complication, and definitely economical. Prospective randomized studies are required to validate the above hypothesis. Next one. Next one. This is our analysis of 200 cases done at Jaipur. All 3 valves, Maya valve, Evolute, Sapien. Next one. Next one. Not a huge difference, almost comparable outcome in all the valves. We had 2 deaths in the self-expandable valve, and that's because one had a sepsis and one patient required an emergency open heart surgery. Next one. Thank you. So we are here. This is our presentation, and we will start the access as an ultrasound-guided access on the right side. And we have a master tower operator, Dr. Gopalamurugan, who's moderating the session. So over to you, Dr. Gopalamurugan.
So, Ravinder, tell us the choice of valve and why this valve, and what is the implant depth that you've decided, just for discussion purposes, whilst you're getting access.
So in our practice, in my practice, all larger annulus, they get a balloon expandable valve. That is for sure, because it's very difficult to control a larger self. We have done, everybody has done those larger self-expandable valve also, but the data clearly shows that a larger self-expandable valve is associated with more pacemaker rate and no real hemodynamic advantage compared to a balloon expandable valve. A very small annulus, I would choose a self-expandable valve. Regarding the implant depth, majority of our cases, we would just like to stay within 3 mm of the below the annulus. So you saw an ultrasound-guided access where we would identify the common femoral artery. Go ahead, show us down, please. Come,
Yep.
Areo.
We saw that.
And then also confirm, yeah, on the floor on the angiogram.
Beautifully demonstrated.
So after this, we're going to put
what is the balloon expandable valve you're using?
Edward Sapien 3, 29 millimeter, which is 3% oversize.
Super.
What would you do in such a case, Dr. Gopalamurugan?
Same. Edwards Sapien S3, 29. Exactly, pretty much what you have suggested.
So, just because we also wanted to focus on the access, we want to show the steps of ProGlide. Here, we're going to make a small nick on the 6 French dilator. That's very important. There should be no skin tag. And you do a blunt dissection with a mosquito forceps. Are you still using 2 ProGlides, or you have switched to 1 ProGlide, 1 angioseal?
So I just go by the vessel size. If they're big, I would put 2. If they're small, I'd put 1. But increasingly, I'm convinced 1 is good enough for most. As you beautifully demonstrated on your study, and there's a large number of patients, Indian experience, that's congratulations on that London Valves publication. So I'm increasingly going to there, but I just go by the vessel size. And if the vessel size is big, then I'm fairly generous. So it's not always 1.
Yes.
I just go by 2.
Yeah. And I agree. That's what the title was provisional. You can use a second closure device if you feel there's a pulsatile flow at the end of the procedure. The wire comes out.
Dr. Ravinder.
So go inside, you see a pulsatile flow, and you come back.
Hello?
Sorry, can you?
Yeah.
Yes, I can hear you, sir.
When the annulus is large, but the alveolar diameter is, it's not so large, then what is your choice of the valve in this patient? The annulus is large, but the alveolar is narrow.
So then you need to understand what is why the alveolar is narrow. Is there a septal bulge? Is there a calcium in the alveolar? Is there a subaortic membrane? Is it hypertrophy? But still, if there is not a huge difference, I would size my valve based on the annulus. But now let's say we would rarely come across such a case where LVOT is extremely narrow compared to the annulus. And then, we would still choose a balloon expandable valve. But as I said, if it's a heavily calcified, maybe rarely you can choose a self-expandable valve.
Sometimes these patients with a severe aortic stenosis,
But the problem with
this the severe hypertrophy of the ventricle itself can cause some LVOT obstruction also.
Yes, so we have, I mean, that's what you need, a full echo assessment and you need a full CT scan assessment. So now we're going to put a stiff wire, and next would be the E-sheath.
So Ravinder, just excuse
Okay,
us.
just
We're
have the
just going to
E-sheath,
switch to
please.
CMC,
Yeah.
and then we're going to come back to you once you cross the valve. Is that okay?
Okay? All right. Okay. Yes,
super.
that's perfect.
Over to CMC, please. Ravinder, we're back
C minus.
to
C
your
minus.
lab.
Yeah. Okay. Perfect. So this is what all we have done. We have a E-sheath in place, and we cross the valve with an AL1 and a straight tip wire. Next one. Then we put an exchange length 035 wire. Next one. And a pigtail. So we are right here. We've finished our hemodynamic tracings. Now we're going to go ahead and choose a Safari extra spool wire. That is our go-to wire for almost all cases at present. Rarely we would use any other wire. And so place the Safari extra small wire into the LV. Okay, so pigtail comes out. Go ahead.
While you're getting along, Ravinder, do you
Why-
use the single wire unipolar pacing to avoid another venous stick at all that's been described? Where
No, let's have the valve.
do you ever use that?
So occasionally, I mean, in one or two live cases we have done that, but let me tell you, I'm not very comfortable with that. So I've switched to totally, I would put a venous line and put a pacemaker.
I couldn't agree more. So just for the purpose of discussion for the audience, this is what I was asking was, there is a technique where you can do pacing from the stiff wire with unipolar configuration, where you put a clip on the skin and put the second clip, the anode or the cathode, onto the wire, whereby the capture, the pacing happens from the wire. But again, as Ravinder said, I get slightly uncomfortable because even a single beat of non-capture can lead to a disaster, especially if you're doing a balloon expandable, because it's less forgiving, and especially if you want precision, even one beat loss of capture can lead to a disaster. So it's probably best to put a temporary wire, although many publications have come out that this is equally as good, but probably safer to put an extra temporary wire.
Push your wire, please.
Hello, Dr. Ravin. The
Okay,
question
so
is, this is a heavily...
I agree with you.
Sorry. Yeah, Dr. Ravin, it's a heavily calcified valve which you showed.
Go ahead,
So you are going without pre-dilatation. So any particular reason in this case?
So, see, one of the reasons why we don't pre-dilate when we are using a sapien valve is, see, it has got a pusher on the outside. And the pusher at the back end of the valve will help you to enter into the valve orifice. So in case now, let us say if it's a bicuspid valve, it's a very horizontal aorta. And those are the conditions where we would pre-dilate with a sapien valve. Otherwise, majority of time, let's see how it goes today, but majority of time, we are able to cross it without pre-dilatation. So this is how we're going to orient the valve. You go slightly cranial, remove the parallax in the valve frame, and then we're going to mount the balloon inside the valve. So keep a push on the wire. Fluoro save. I'm going to do a fine adjustment. Show me the valve frame fully.
So how many of you actually pre-dilate?
not in the
Raise your
best
hands,
position.
please. Pre-dilate routinely. So most
Wire.
don't
The
pre-dilate. So I think it's largely down to the type of valve you use. I think increasingly with balloon expandable, you don't need to pre-dilate. Again,
Go
the
ahead,
type
Leo.
of balloon expandable, as Ravindra said, with a pusher, it is almost
Push the wire. Let the wire go in. Hold the wire.
difficult
Yeah,
to come
hold the wire.
across a case
Perfect.
where you
Don't
cannot
let it go too
cross
far in.
because you didn't pre-dilate with a Sapien S3. And almost certainly you will get full dilatation, what you intended to get with a balloon expandable. But perhaps may not be the
Fluoro
case
save.
with self-expanding.
Come
And
to the
again, what's the
deployment
kind
angle.
of self-expanding? With evolutar, get away most of the time. But if you used a softer valve, let's say the Accurate Neo 2, it is impossible. You will have to pre-dilate, and probably you'll be lucky if you get away without post-dilatation. So it's a very soft valve. I think it's a
Fluorosave?
type of valve. And the Accurate Neo 2 for a for a bicuspid is an absolute no. So I wouldn't even attempt it.
That's okay,
You
that's
need
fine.
a
Don't
lot of
do that.
radial strength. Evolutar or a My Valve or Sapien 3 will be the choice. Bicuspid.
Yeah, so you saw how it crossed. And the other thing which you have to also assess, are you on the outer side of the curve or not? Give
Pre-dilate
an
with a
injection,
small
please.
sized balloon, what is the downside?
The downside is we are all trying to
So-
avoid instrumentation. The more instrumentation, the higher the risk of stroke.
So-
And if you have a platform that doesn't require pre-dilatation, you don't need to do it. And a Sapien 3 or a MyVal, although I don't have any experience, I think it'll be fine. But Sapien 3 almost always goes through. I'm yet
So-
to see one that doesn't go through.
Sorry to interrupt you guys. I think we are right. We are at the position and we're going to go ahead and deploy. What do you think about the
For a
position?
balloon
Let's take one more
expandable.
picture. Inject.
What valve was it?
Okay, so we're going to go ahead and deploy Dr. Gopalamurugan.
I think
Is
again,
that okay?
with the pusher, with the Sapien 3, it goes in. Merrill, I don't know. Maybe it doesn't have a pusher.
Okay. Inject.
There's a
Sorry,
lot of
that's a good
discussion
position.
on pre-dilatation, Ravindar.
Pace at 180. Yeah, okay, so we're going to go ahead and pace at 180. Inject. Start going up. Okay, fully inflate. 1001, 1002, 1003, deflate. Okay, fluoro save and stop pacing. Fluoro save, stop pacing. Okay. Okay, resuscitate the patient a little bit, please. Okay, so we're going to come out, remove the catheter, keep the wire in place. Okay. Okay, good. So pressure is coming up.
That's a very valid point. Now about why should we pre-dilate? Why not pre-dilate routinely? Why not pre-dilate routinely is the question. I think we are in an era where we cannot afford to have a
Put a
problem
pigtail, please.
from a TAVR because it's an expensive procedure, and the outcomes now
put a
are
picture.
extremely good. If you pre-dilate, your chance of having a stroke is much higher. There's no doubt about it. Even a native valve or a bioprosthetic valve. Bioprosthetic valve, absolute no.
Play
No
the
pre-dilatation
deployment.
at all. So if you have a valve technology that would allow you to get a good valve diameter, be able to cross without pre-dilatation, that has to be the best way forward. Unless you have an anatomy where you cannot do without pre-dilatation, such as a bicuspid with severe calcification, then yes, you can do a pre-dilatation, A, to allow your kit to go through, and also B, to give you an added imaging confidence about the size of the valve you're going to use. For two reasons why you would do is a pre-dilatation, but otherwise routinely we don't use pre-dilatation because the systems are just so sleek now.
Gopal,
Yes.
I think, Gopal,
Yeah.
yeah,
play the
the
deployment.
one
play the
thing is
deployment.
proven that pre-dilatation minimizes the need for a post-dilatation. And in my book, there are 4 situations where you will prefer to do pre-dilatation. If the aortic orifice is so very small, but that merely space-occupying property of an ingoing valve this reduces the hemodynamic to a very uncomfortable level. In that situation, when you need some time
Do a 2D.
to precise positioning, you need little time. Your comfort level is higher when very tight aortic stenosis has been pre-dilated. 2, bicuspid valve, for sure, everybody will pre-dilate. Very heavily calcified valve where you find that the entry could be difficult, I think instead of struggling, you predetermine to do a pre-dilatation. And finally, 4th, when you want to size, when you are in doubt, or when you want to make sure that the coronaries are likely to get obstructed or not, then also you pre-dilate. I do not know the fifth condition where you would pre-dilate.
Yeah, I think minimizes the chance of post-dilatation. That's largely down to the valve technology you use that I alluded to earlier. So if you use a self-expanding, pretty much you will end up post-dilating, especially for a bicuspid anatomy or even for a tricuspid with severe calcification. For a Sapien S3, I don't know when the last time I really post-dilated. We just go straight. It always does the job. But of course, in a center where you're new to the system, you want some time to adjust, then yes, of course, it's reasonable to predilate. But if you predilate, you risk a stroke or a TIA. There is no question about it. But you can put a sentinel, but we don't use them routinely because there's no evidence unless you're doing some high-risk maneuvers like lampoons or basilicas, then yes, we would put it in. But before even Sentinel came, even with all this, we never had a clinical stroke. But the point is, I think with bicuspid severe calcification, to get an added imaging modality about coronary obstruction risk, valve size, I think it's very, very useful. Point well taken.
Because the patient get to 50.
But I just logically feel that to dilate, pre-dilate, you dilate with the balloon. And when you do not pre-dilate, in any case you dilate the stent, the valve stent. The balloon expansion creating trauma, more or less identical whether it's done pre or post, because ultimately you have to dilate.
Can
I
I-
don't know why would it
Can
be
I
more-
add something, sir?
Yeah.
Yeah.
So,
on, Ravindar.
no, that's a
Can I
very good
add,
discussion of pre-dilatation versus pre-dilatation and no pre-dilatation. In a self-expandable valve, like an Evolute R with a Portico, Navitor, and the Boston Scientific valve, there is a interaction between the force of the leaflet and opening force of the valve. So softer the valve, more the pre-dilatation you need. Now you look at the Boston valve, you have to pre-dilate with an average diameter of the short and long axis. You're not even choosing the short axis. And that's because you know that the lower end of the frame might not be able to fully open a calcified valve. With the balloon expandable, this is a combination of pre and post dilatation together. It's just about how a pre-dilatation can only help a balloon expandable to cross the annulus. Nothing more than that. But if you think you'll be able to cross the annulus without an issue, the pre-dilatation is not required.
So
That's what I think.
So
And
Gopi,
self-expandable for sure pre-dilatation in almost all the cases.
so Gopi, if
Yeah,
you are talking about
Amit.
stroke and dilatation, most of the studies suggest that stroke happens during post-dilatation and not during pre-dilatation. That's what the
Okay, come down,
studies
please.
suggest.
We're going to go ahead and close the
So
drawing.
I think we're getting it wrong.
So basically, less instrumentation. So if we can stick to one dilatation, and if that includes the valve in
The reason
deployment
why-
also, that's got to be the most
The
logical
reason
thing
why
because you don't get pre-dilatation, post-dilatation, and the valve with the balloon expandable.
So the reason why post-dilatation causes stroke is now you have a stent frame, you have a calcium.
Okay.
When you are dilating it, there is a chance that that calcium may break up and go above. In a pre-dilatation, you don't have that fact.
So with all the discussion, if you can conclude, we want to predilate in a bicuspid aortic valve, heavy calcification, what I said, horizontal aorta, and all self-expanding valve.
And self-expandable.
Are we at this
self-expand-
consensus?
correct.
All self-expanding
Almost
should be
all.
predilated.
Yeah. And balloon expandable, even in bicuspids, you can get away without pre-dilatation. That's advantage of a balloon expandable. Yeah.
Okay, so I think we are done from our side. We already showed the hemodynamics. There's
I have
no
a very
gradient,
basic
no aortic
question.
Dr.
regurgitation,
Ravin, what
which
was
is
the-
We
very
find
rhythm
it
of
very
the
difficult
patient.
to
Is it
identify
basic?
bicuspid aortic valve even on transesophageal echo or
No,
other state.
no.
Is a CT scan 100% tell you that it is bicuspid aortic valve, or do you have problems that you on table you find that it is?
Almost
us
99 to
DSA down,
100%, a good quality CT will tell you the anatomy. A good quality CT, whether it's a type 0, fused, whatever type of bicuspid. So in answer to the
down.
question, I think TOE and echo,
Okay,
not
ready
good
for
enough.
injection,
Because
DSA?
so much artifact, very difficult unless you have a nice anatomy. Otherwise, CT will definitely tell you. Great demonstration, Ravinder. We really enjoyed
Inject.
it. Beautifully done, as always. Excellent valve deployment, and we can see the DSA looks beautiful also. So if you have anything to add, please
just want to
let
add
us
in
know,
this.
educate us. Otherwise, we'll move to the next lab.
Ravinder, I have a question for you. Dr. Kane here. Can I?
Yes, sir.
Yeah,
Yes,
can you,
sir.
when you
Hi, good
say
morning.
you are using only, good morning, when you are using only one ProGlide and then if necessary use per close, but a lot of other people are against per close because of so much of downside of a per close. So have you faced any problems after using per close? The major downside is you cannot take a puncture on that side, and then the other downside of per close. So what is your, how do you look at those things?
So when we started the vascular closure device, we were all using 2 ProGlides because the system was 18 French, or maybe the OD was 20 French. Now we have come down to 14 French. So what has been accepted in London Valve, you do 1 ProGlide, and the second closure device is an ad hoc device. So the second closure device could be an angioseal or could be a ProGlide per close. It's all same. And how we choose, if there's a pulsatile flow, use a vascular closure device, which is a ProGlide. But if it's no pulsatile flow and it's just some oozing, then we would go ahead and do an angioseal.
So Dr. Ravin, just a question that with angioseal, I think they recommend...
And suppose if it's a small vessel, then don't do anything. Ask your fellow to hold for 15 minutes. At least you'll not do any pinching of the vessel. You have converted a 14 French hole to, let's say, a 2 French or 4 French hole, and a manual pressure would be good enough. You were asking something, madam?
Yeah. Dr. Ravin, with angioseal, they say the repeat puncture, you have to wait at least for 2 to 3 months from that side?
Yes.
That we have to, at
4
least we
to
have to
6
told
weeks.
that. You cannot
But
go
you
for...
should know,
You should not puncture that side for at least for 2 months.
you can choose a different spot.
Okay, you can still do it.
You can go a little higher.
Higher, yeah.
You have to go a little
So the question was from audience. Just because I'm having the mic, I'm asking it. What happened
Yeah.
to the gradients? Can you just tell us what were the pre-post gradients? Somebody in the audience wants to know.
So, yes, so we did that invasive hemodynamics. There's no gradient. Pre-procedure mean gradient was 70. Let's do an echo and show them. Can you see the echo? Can we slave the echo? You can see the echo mean gradient is 2.67, peak gradient is 6.51, and velocity is 1.28.
Okay, great. Excellent demonstration, Ravinder. Enjoyed it. Masterly done, as always. So thank you very much for being here, Ravinder. Thanks to the entire team. Excellent. And
thank you.
Great show. We'll switch over to CMC, please.
Thank you. Thank you, Dr. Gopalamurugan, for moderating, and thank you so much.